Hello, and welcome to the Dr. Money Matters podcast, the show where we discuss important financial topics that were never covered in med school. I'm your host, Dr. Tarang Patel. This episode is about employment contracts. Don't fall asleep. This episode is packed with information about what you need to look for before signing your next contract. Many healthcare professionals change jobs more frequently than they have in the past, and even if they stay where they are, the terms of employment may change. You need to be aware of the key items in your employment contract. My guest today is Jon Appino of Contract Diagnostics, a contract review firm in Kansas City. Jon and his team only deal with physician contracts and have a ton of experience in this field. This is a longer episode, but I encourage you to listen to the end. It could save you major headaches before you sign your next contract. Welcome to another episode of the Dr. Money Matters podcast. Our guest today is Jon Appino of Contract Diagnostics in Kansas City. Jon specializes in contract reviews for physicians. Welcome, Jon.
Yeah, I appreciate you having us.
Give me a little bit of background about yourself, about how you go background and then how you kind of focused in on physician contracts.
Yeah, so it's interesting. You know, I've got a lot of physician friends, and I've always been into new ideas and ways to help a lot of different types of people. And I started a business when I was 17, and another when I was 20 in college. And I've always kind of had my eye on different ways to help people and provide a better service or better value proposition to people who are in need. And when I finished my undergrad degree, I took a job with a pharmaceutical company, and I learned a lot about medicine and about physicians, and I had a lot of different roles in a lot of different cities across the states and a lot of different divisions, and ended up working a lot on contracts. And some of my physician friends, as they were coming out of school and they were finally getting to that point where they were finishing their I'd been working for a few years, and they were finally getting to that point where, they were finishing and they were getting jobs. And there was kind of two things that they were really kind of frustrated with. One was the whole recruiting process and how challenging that can be, and, third-party recruiters and hospital recruiters and that kind of thing. And then the other piece was, how you come out and you're a clinician, and then you're given financial responsibility with a much larger income. And sometimes that's challenging on how to handle it. But then a lot of times that's usually governed by a employment agreement, and they can be 5 pages, they can be 70 pages, they can be written like a paragraph, they can be written extremely intricate. Compensation structures had been changing quite a bit back at that time, and it just seemed like there was no good place to turn. And so I had a couple of physicians, friends that had a local attorney look at it, and they said, I gave him $400 and they told me it looked good, and I was done talking with he or she 5 minutes later, and I was off, I was working, I was earning. And I said, but do you know what the contract said? And they said, well, no, they told me it was good. And, and I said, well, how are you paid? And they said, oh, I don't know. They pay me an RVU number. And, I said, well, is it a reasonable number? I said, I don't know. The lawyer didn't know anything about that. They just said it's legal. You can go ahead and sign it now. And I thought there's got to be a better way to, number one, educate people on what it is they're signing. Let them know, from a deal perspective, what's good and not good and what they should ask, and tell them what they don't know just by having a box checked by saying it's legal or not, realizing that most employers probably give legal contract, and then doing a better job with the compensation. So we set up a company, and I put together a great team of attorneys and benefit experts and folks who just help with a lot of documentation and paperwork that we do, that look at the process of coming out of school, getting an agreement, understanding what it is, asking the right questions, not the questions that maybe employers find annoying, or they're not going to change things in the contract, or they don't understand why you're asking, but giving them good advice on what to ask and how to ask it, because physicians haven't negotiated contracts before. They don't know even how to ask for a certain provision, because knowing that it's not only what you ask but how you ask it. And so we basically walk them from start to finish on what they're signing, why it's important, what questions to ask, everything from the pitfalls from a legal perspective to a compensation perspective and a benefits perspective, and what they currently don't know by just signing something that they've been told is quote unquote fine. And so we put together a great package. There's a bunch of different packages that we have, and everything's super easy for the physician online, from scheduling a review to booking a time to having access to us. We've created a company that 100% dedicates itself to this. We don't pitch you guys anything else. We don't sell you disability insurance, or we don't keep your information in a database that we use for recruiting or sell to recruiters. We just do contracts. And so it's our specialty, which physicians obviously can appreciate being specialized and focused in a certain area. And that means we can talk to RVU structures. We can talk to macro. We can talk to, bundled payments. We can talk to, government incentives, and we can talk to all those things because we know about them. It's not just a, quote unquote legal review. It's much more.
Okay.
So,
and how long have you guys been doing this?
I don't know. Time flies. I want to say 6 years, 5 years.
Okay.
Something around there. We've got a lot of folks who went through our system, a couple of years ago. They're coming back for partnership documents. So they're coming back because they're shifting jobs. As you know, the data is pretty robust as far as physicians who sign contracts who end up not re-signing or not going with that employer again. So we're having a lot of our, some of those initial wave of folks come back through. And then we've got a lot of residents and fellows you could imagine this time of year that are coming through and getting all set up. And so yeah, we're busy, we're full, and that's how we like it. So we're able to provide a lot of good value to physicians.
Perfect. Well, that's what we want to hear. So let's kind of just go into some of the elements of basic contract. So obviously you talked about this, right? The first thing that everyone is concerned about is obviously compensation. So they usually will have in your contract a couple of different aspects related to compensation. And for many starting physicians, you may have a base salary, you may have some productivity measures, bonus measures, things like that. So tell me, what are things you look for? Obviously, the salary or the compensation varies from a first-time coming out primary care resident to a highly subspecialized surgical subspecialty. Things can be variable, but there's some elements of contract that can apply to all those things. So if you could just kind of give me an element like what you guys are looking for in a base compensation type of structure.
Yeah. So more than anything, we just want specifics and we want details. The thing that we don't like is when things aren't clear. And, obviously if it's whether it's an hourly rate, or it's a shift rate, or if you have a base salary and that's it. If it's a base salary plus an incentive, obviously incentives can be from lots of different things. We're seeing an awful lot of quality incentives. We're seeing a lot of places go from individual productivity to pooled productivity, or, pooled productivity plus a quality metric, as they're trying to find ways to incentivize physicians in other ways than just more care, and the quantity as different payers and different things change with how they're looking at things. We're seeing compensation models change as well. So a lot of it just depends on if it's a private practice, if it's a corporate job, if it's, you get paid per unit or per shift. It all just varies so much. But more than anything, the thing that we want more is just specifics. We want the contract to say when things are going to get paid. So if it's a yearly bonus, is it a calendar year? Is it a contract year? Is it a fiscal year? Is it an academic year? What happens on termination for the bonus payments? If you have a base salary plus bonus, how do they calculate it and pay it, if at all, on termination? And we just, again, want specifics. So what do you need to do to earn the specific metrics that they're setting in place? And things like discretionary bonuses, lots of employers have those. Obviously, we don't like them because it kind of violates that first rule. There's no specifics. At the end of the year, we may or may not give you a bonus. Is it $100? Is it $100,000? Is it paid? Is it prorated? Is it paid no matter if you are not employed? What are the metrics? So more than anything, we just want specifics, and we just want it clear to the physician how he or she needs to produce or to provide the certain metrics to earn the certain dollars that are on the table.
And are you seeing, as far as let's say base compensation, are you seeing that tied to some sort of standardized surveys, especially I guess when it's more hospital related type of employment, like the MGMA, AGMA kind of surveys? Mm-hmm. And I guess the question that a lot of people have is, are those are they accurate? Are they, are pretty much physicians able to hit that base salary and then, move to the productivity levels? Because I've seen contracts where, they have a very nice base, and then they talk about, okay, if you hit this level of RVU production, you get this base. And it's very nebulous on how you get to those levels. Mm-hmm. So I guess, over the last few years, you said you already mentioned you're seeing some shift towards quality. How is the productivity changes other than just going towards quality? How are you seeing those things change?
Yeah. So, great question. As far as number one, how accurate is the data? the data is broken out into multiple different ways in multiple different areas, and certain specialties obviously have more, but it's a survey. And so, they reach out to people and people take the survey or they don't take the survey. And even though like NGMA is the largest survey out there, not everybody takes it. And
right.
as you can imagine, there's survey bias. So physicians who are making really, really good money, they're the top 0.001%, they're probably not taking the survey,
right.
And so the survey is a little biased in some areas. And that's why it's good to have not just the data, but somebody that can kind of interpret it. We have an internal database here that we keep that's blinded that just says, these physicians in these areas make these kind of dollars and these kind of RVUs. And so it's just raw data. And so that can be very valuable when we're looking to peg a certain, position in a certain area, whether it's rural or metro or somewhere in between. But as far as how other physicians are hitting it, we always like to have and give our physicians the good questions to ask the employer. So what's the average of the other physicians there? What's the range? What's your expectation for me? What do you think I'll do in the first and the second and the third year? And just to kind of know those things, most employers, set out on investing and hiring a physician, somewhat knowing what those numbers are.
Right.
And that's why I think it's good just to have the right questions to ask the employer at the right time when you're going through the interview or the negotiation process. And at the end of the day, it's just knowing, what is possible with that employer and how they have their efficiencies set up and the other physicians that are there. If it's a new build, obviously there's a lot of unknowns. And so we like to have longer income guarantees, longer base salary guarantees in those types of positions, not knowing what kind of, opportunity lies ahead for the physician in terms of that. But we also see sometimes, in maybe less desirable areas, we see these really, really big salaries. And then the bonus metrics that they have, maybe you're guaranteed for 2 years or sometimes even 3 years. And then there's just not the ability to produce at that clip. And so unfortunately, the physician has a big reduction in their salary when it comes to that third or fourth year, sometimes even second year, because they just can't produce at the clip once the guarantee runs out to continue at the production level to keep up their income. And so a lot of times those are transient positions, and you see physicians kind of in and out. So it all varies, but I think the thing is just to have the right questions to ask the employer at the right time during the process, and then understand how other physicians are paid and compensated, and then how the compensation model has changed in the past or how it may change in the future, whether it's in going from an RVU structure on an individual basis to a pooled bonus, or whether they're integrating more of quality in there. If it's a quality bonus, what types of metrics do they measure? And then are those things that you as a physician can control? A lot of those things are difficult for the physician to control as well. So again, at the end of the day, we just want the physicians to understand what the metrics are, know that they're reasonable metrics, and if there's any changes that are pending.
Good. Very useful. So let me ask you, because of the shift towards quality, and we're all hearing the terms MACRA, PQI, all these board certification, limited and recertification, things like that. What are you seeing? I mean, give me a specific on a contract you may have seen recently. That how are they assessing quality? And it's secondarily, like you said, what are the things that the physician may have been able to control, may not have been able to control? Give me a little bit more specific, because that's a very interesting topic that you brought up.
Yeah, it is. So we see quality metrics showing up more and more, and a lot of the things are. It all depends on specialty. Sometimes we'll see we may see like an endocrinologist linked to blood pressure and HbA1c levels and those kind of things. We may see some that are linked to maybe even a % of generic medications used, or we may see an emergency medicine physician linked to certain throughput times in the ED. A lot of times we'll just see we see hospitalists that are based on patients' overall satisfaction, because a lot of employers look at hospitalists as kind of, the quarterback, right? They're the ones that are finding they're sending the referrals in, they're making sure that everything is coordinated, the patient's in and out at the right time, discharged with the right information. And, so when the patient leaves, a lot of places are looking at the hospitalist as, was the patient stay, reasonable? Would they refer their friends? Did they think that they were satisfied, quote unquote? And a lot of that's within the hospitalist control, but a lot of it's not. If one of the physicians they refer in is maybe in a rush, or maybe not in the mood, or maybe feels that the consult was unnecessary, or the wrong consult was made, or, who knows, maybe the food was not very good and the patient's complaining about the food,
Right.
Or the nurse had a bad day. I mean, there's so many things that when you look at overall patient satisfaction, that can just be challenging to grade a physician on. And we are seeing that a lot. And it's, And sometimes it's 10% of the quality metric. Sometimes it's a much larger portion. And so it varies a lot by specialty, but we do see some of these things that we feel that the physician maybe doesn't have as much control over, and yet they're tying the physician's compensation to them. And sometimes it's a small fraction of what the physician's earning. Sometimes it's a much larger piece. Sometimes it goes up over time. So it just all depends. But
absolutely a good point, because I know that there's a lot of physician concern about this because, like you said, the food wasn't bad, the room wasn't cleaned properly. Well, that all ties in with satisfaction, though you had nothing to do with it. And so are you seeing that is something that they're negotiating on? I mean, even if it's a small fraction, it's kind of a point that the global picture of the hospital satisfaction may have some reflection on the physician, but like you said, it's obviously not the whole story. Are the employers, are they flexible on this point? Or
Great question. So most of the time, these are standard policies for a specific specialty or a specific division, or maybe all employees have a certain percent tied to metrics, because as hospital leadership wants to align physicians with the same goals, they want everybody to be incentivized in the same way, not just themselves producing lots and lots of care and lots of quantity, but having an overall good experience for the patient, so they continue to return and send their family members. That's good for overall business. Right. And so we see a lot of leadership kind of aligning a lot of physicians around kind of the same mutual goals. I think one of the more important things is as we're seeing hospitals go more towards these structures, sometimes we're seeing, a physician may start with a, production incentive, but the quality incentive maybe it's something that they're working on. We'll negotiate contracts for physicians, and we'll be talking about the production incentive with the employer, and they'll say, well, yeah, but this is going to change next year because we're going to this new model, right? And I think what's important as hospitals go to new models is that the physicians are requesting or negotiating that first year, maybe even the first 2 years of any at-risk compensation be guaranteed. Because if the hospital doesn't do a good job of setting the goals or setting the metrics or compiling the data, right? I mean, even if you have wonderful patient satisfaction and the surveys go out right on time and everything is collected, if you don't compile the data and then present it back in the right way, it's all for naught. And so we're actually sometimes negotiating and wanting physicians to have like a first year guarantee. So just for simplicity's sake, let's say that $30,000, let's say a physician makes $300,000 and 10% is of their compensation is around quality. Okay. So, I think they could have 300,000 total. The 30 is at risk. So their salary is annualized at 270, right? Right. And then the 30 makes it 300, or they could be annualized at 300 and the 30 would be on top. A big difference. Absolutely. Right? And if you don't ask, you don't know, right? So is it 10% at risk, or is it in addition to it's an incentive? And so number one, obviously that's important to ask. And then number two is, if this is a new thing, let's make that $30,000 in year one, maybe even in year two, guaranteed, because I don't want the physicians to be suffering or financially, harmed, if you will, by a hospital leadership that does not accurately project or collect or promote a program that the physicians may have a ton of control over or may not have any control over. And so we'll do some of those kind of things. But as far as will they negotiate, I want a certain metric in or out, most of the times it's more division specific. Okay. But those are some things that we'll be able to negotiate as far as I want it guaranteed to me in my first year, because I'm not quite sure you guys are, with all due respect, I don't know that you're going to do it correctly. And if you don't, I don't want to be harmed. And so those are some things that we'll negotiate as far as some of these unique mechanisms for bonusing physicians. Okay, good. Okay, that's a very good distinction, because I think most of us, you think of the number and that's what you get focused on, but how does that number really calculate? And that's a very obviously important way of looking at it. So good. Okay. So compensation, obviously the major concern for everyone, but let's go to some of the other components of a contract: benefits, health insurance, retirement plans. What are some of the things that, we should be looking for those in that part? So a lot of physicians want to see specific details about benefits in contracts. Some employers are able to put that in there. A lot of employers just have a little paragraph that says you'll be offered our benefits. And then maybe they provide like a separate packet or a separate, maybe it's even verbal kind of discussion around their benefits. It obviously depends on if you're signing with a smaller practice or a big corporate, entity that has, like a nice fancy all colored PDF brochure and everything. But The thing that we want to know is, again, benefits typically are non-negotiable, right? They apply the same to most all physicians. And so if that's the case, we want to know, when was the last time they were changed? Are there any plans on changing them in the future? Knowing that benefits, can and probably will change. Right. If malpractice is classified as a benefit, we want to make sure that the malpractice is not one of those things that can change. Mm-hmm. Right. Or if it does, then it definitely has a notice period. So that the malpractice can only change upon notification of the physician by 90 days or 120 days or something that gives you guys enough time to plan either to leave if you don't like how they're changing it or to plan for, negotiating something else into the contract regarding the malpractice. But most of the time, malpractice is not considered a benefit. So that doesn't apply. But for the rest of the benefits, we want to know, number one, when do they start? So if I start on July 1st, does my benefit start July 1st, or does it start later on? Maybe because of the way the week flows from a weekend to a weekday, mm-hmm. maybe my employment starts on July 4th, right? Or July 6th. And so if that's the case, a lot of policies have a waiting period of 30 days and then the first of the month. If you start employment on July 6th, it sounds so simple, but your benefits, you have 30 days, you're looking at August 6th, first of the month is September 1st. So you may not have health insurance or vision or dental insurance or any of the other insurances all of July and all of September. If you finish your training in June, that might be a big consideration. COBRA could cost you $500 a month. It could cost you $2,000 a month. It just depends. And obviously, the current Affordable Care Act states that people have to have insurance. It's required. If you have a delayed start date, maybe people want to take some time off and study for boards, or even do their boards, or just take some time away before you start full-time work. There could even be a longer delay in when you have medical insurance. That's an often overlooked aspect of the benefits. And then obviously we want to know what you need for disability and for life insurance based on the individual physician's situation. Is it enough? Do they need to buy more from a third-party vendor? And if so, like I said, we don't sell or pitch that stuff here. There's lots of good quality people out there in a seemingly crowded marketplace that can provide that. But and same thing with the retirement. Is there a match to any of my contributions? If so, does it vest over time or is it right away? If there's PTO as part of a benefit, we want to know, does a PTO roll over if you don't use it? Is it paid out if you're terminated and don't and still have some left in the queue? So those are some of the benefit questions that we'll make sure physicians are aware of as they're going through these benefit statements. Good.
Okay. And you addressed this, but let's kind of go into it a little bit more. So malpractice coverage, like you said, yes, they can change. I think so. Obviously, the two types of malpractice: the occurrence and then the claims made type of policies. Mm-hmm. But go into a little bit more of what you're seeing as in malpractice. What types of coverage are you seeing? What are the issues that contracts are having?
Well, I think issues, again, sometimes it just becomes on having specifics in the contract. Sometimes very important things that are needing to be in there just are not. And so number one, we want to know what the physician has, and we want specifics in the contract. And then once we know that, then we can start asking questions and providing some potential modifications and negotiation topics. Mm-hmm. But we see occurrence plans, we see claims plans, we see modified claims plans, we see self-insurance, we see lots of different ways. But I think the most important thing that is specific on what you have, what the limits are, if the contract ends, what the requirements are for both parties, that's fairly balanced, those kind of things. But we see a lot of contracts. It seems like recently that they'll even say, you'll have malpractice insurance. If it's a claims policy, this is how the tail is paid. And so it's like, we don't really know what it is. So we always tell the physician, the first question to ask is, do I have an occurrence plan or do I have a claims plan? Because if it says, if it's a claims plan, you'll buy your tail insurance. Well, if it's not, so that may be very concerning.
Absolutely.
Or it could be irrelevant if you don't have a claims policy. If you have an occurrence plan, then you don't need it. And so we'll see things like that again, employers like, because it allows the employer flexibility, change or modify their plans without having to recontract all of their physicians. But obviously, as a physician who's signing a contract that says, I'm agreeing to these terms, you want to make sure that you understand the terms, and that if they're going to change, you, number one, have notice, and number two, are agreeable to the terms, because if you're signing a contract that pays you X dollars to do X work for X number of years, and all of a sudden you think that and you're agreeing to what you think is a occurrence plan, so I'm accepting your compensation knowing I do not have to buy tail. Well, all of a sudden, if you have to buy tail, maybe that changes your agreement to the compensation. Maybe you should have made more money to purchase your tail and make the risk more reasonable with your situation over the years.
Very good point. Very good point. Yeah, sorry to interrupt. That was a very good point, and I want to get that across to our younger audience, because the difference between claims and buying a tail policy versus having an occurrence policy can be, tens, maybe even hundreds of thousands of dollars, depending on your specialty. So that's a very good point, because if you've worked at a practice for 3 years and now you're responsible for the tail policy, you may have to come up with a huge amount of cash that you didn't plan on. So yeah.
Do we have time for a quick story?
Sure, please.
So we had a physician who was moving from a metro area on the East Coast down to an area of Florida, and they had been out of training. They were an OB/GYN physician. They'd been out of training for 2 years in an expensive metropolitan area that was earning around mid 200s, okay, like 230, 250. So expensive area, not a chance to save a whole lot of money, and they had a policy. They didn't have their initial contract out of training reviewed, and so they didn't really know what they needed. And so they had called us and said, hey, can you look at our contract that's coming up in Florida? And we had said, sure. So we looked at that contract, and the employer actually did not carry malpractice insurance at this place in Florida, because it was a highly litigious area.
Right.
And they felt that, that insurance was created more of a target than a protection. Right. And so their decision was to not carry it. Her current, so they wouldn't let her continue the plan that she was on. And once we reviewed her contract in her current job that she was going to leave, we found out that they needed to purchase her tail insurance, which was a surprise to the physician. They did not know.
Right.
And so number one, they had to buy a tail. They didn't know how much it was going to cost. And number two, they couldn't just continue to maintain the policy to cover any prior acts, because the current employer didn't want them to have a policy. And so they had to tail out of that plan. It was a 2-year OB/GYN plan.
Okay.
It was $180,000.
Wow.
Okay? And it's different than if I take out a loan to buy a car. If I don't make my car payments, they take my car, or they take my home if I don't pay my home. With a tail policy, there's nothing to take.
Right.
There's no hammer in the deal. So what happens is you have to pay for it. You can't finance it typically. And so, you're 2 years out. You don't have a lot of money saved. You now need to spend $180,000 to buy your tail. It can create a very, very bad situation for somebody who just did not understand the expectation. So when it comes to understanding the contract, it's a good story, number one, because it says, look, no matter who does it, us or somebody else, make sure that everybody has their contract reviewed and you understand what it says. Because the few bucks up front it could be a very, very good investment. And then obviously knowing now what you know, you can make the appropriate career moves based on that. And so not knowing can be very, very costly.
Absolutely.
Or having a policy that can unilaterally change by the employer without you knowing or without your consent can obviously also be another game changer.
Well, and I think the take-home message from that is just to not be an OB/GYN practicing in Florida, right? That's what I'm getting? No, just kidding. Yeah. But no, those are the nightmare scenarios that you hear about, but they do happen. And it's very important. Like you said, if you took a little bit of time ahead of this situation, you could have prevented it. So, and I've had other guests basically say similar things in other veins, talking about, an ounce of prevention is obviously worth a pound of cure. So a good story. And unfortunately for that person, a very expensive lesson, but hopefully some of the listeners can benefit from. So let's continue on. So another element of the contract would be the professional expenses, such as CME, medical education, licensing dues, things like that, and then even moving, relocation type of thing. Obviously you say specifics are important, but anything that you're seeing in there that kind of is something that people are kind of overlooking?
I think just knowing what's covered and what's not covered. Sometimes you'll see a budget for something. Maybe there'll be a $2,000 budget for professional expenses. But knowing, does that mean from when you're employed, or does that mean for expenses regarding this position? So you may have a $1,000 fee for a state license that you pay today, but you don't start working until 3 months from now. Can you keep that receipt and submit it as part of your reimbursement, or is that only for expenses that you incur as an employee or as an independent contractor? So I think just knowing what the policies are is one thing. Some places have different amounts if you're single boarded versus double,
right.
And so if that's the case, obviously we want to make sure that we have the correct amount put in the contract based on your, the amount that you'll need. And then just, again, it's good knowing what the differences are in different areas of the country, different specialties. If you are in an area that has a lot of conferences, the Orlandos, the Chicagos, the New Orleans, the San Diegos, you probably don't have to fly out as much as if you're in, Billings, Montana.
Right.
And so, some of those things are good points to make sure you understand, okay, would I need more or less based on my current location and situation? So, right. I mean, from a CME and like an expense, thing, I think that's, those are just kind of some of the higher end stuff.
Now, one thing I think that people have, kind of a vague idea about is that there are some terms in the contract that actually will define your clinical duties. And, you may be hired by a hospital system to be, let's say, a neurologist at a specific hospital. Well, then that hospital merges with another one. Now, all of a sudden, you may, be expected to have coverage at another place. So how are those kind of things addressed in a contract, and how do you protect yourself or prepare yourself for those kind of things?
Yeah, that's a great question because, again, I know we've talked a lot about it. It's about specifics. We basically look at contracts from our end as it's just about expectations, expectations from the physician of the employer and then vice versa. And so in essence, what the contracts say is, what are we going to pay you? Mm-hmm. Right. And then what do you got to do for the pay? And so that's why, again, we talked about compensation, how we want very granular specifics around what, around the amounts and the whens and everything else. And so so the flip side of that is the expectation of the physician. And so we definitely want specifics on the location. Can it change? If so, what kind of notice? Does a physician have any say to the location? We've seen physicians, we've seen hospitalists, look at two different opportunities in a certain area with an employer, one with a closed ICU, one with an open ICU. And they say, I'm interested in this one, not that. They sign, they get down there, they're assigned to the wrong one or the one that they thought that they did not want,
Right.
And so, so those are obviously important things. If your location remains undefined, they can send you to outreaches. They can have you drive more, that may impact your production level, right? So right. There's things that have downstream effect. And then the same thing goes for hours. Now most physicians don't go into medicine to punch in at a certain time and punch out at a certain time, but we still want specifics, again, what's the expectation? Is it, if it's a 5-day work week, is it Monday through Friday? If there's call involved, how is it structured? Is it capped? Do you get paid for call? If so, how do they determine who takes what call? If you're a hospitalist, something as simple as it days or is it nights to be distilled in the contract? What are the shift times? I think there's so many details when it comes to the location and when it comes to the schedule that typically just aren't in contracts. And we understand that employers, their intent is not to leave it vague. So when you get there, they upset you by giving you a terrible schedule and send you all over the place. We realize that that's not their intent.
Right.
But, like I said, we could tell lots of horror stories. And so that's what we want, just specifics, or at least if nothing else, if they can't put specifics in the contract, we want the right questions asked. But the other thing that you brought up was the consolidation in healthcare right now. And you're seeing a lot of mergers, a lot of acquisitions. You're seeing private equity come in into certain specialties.
Absolutely.
And buy, larger practices and merge them and make them efficient and make the physicians employees and really, find ways for highly profitable specialties to treat them, again, to provide great patient care, but also as a very profitable business. And so knowing, what the future looks like. And again, that's why it's important to, have somebody that you can talk through who does a lot of this kind of thing so they can tell you kind of what the trends are in either geographically or specialty wise around a specific, opportunity. And does it make sense to protect yourself in those situations? If you sign and then the practice that you just signed with is a private run and they recently sell out, are you part of that deal? If so, what's the assignability of your contract? Do you have the same terms and the same clauses? Could the acquiring entity, if you will, change those or make you not part of that package deal? And so, having, again, the right questions to ask the employer at the right time without sounding like you're digging into something that's not there, right. is important. And I think it's, again, depending on the situation, it's important to know, what those questions should be. And then, when the employer replies with their answers to make sure that you have someone to bounce those off of to know if they line up with the way that they should or if they bring up more red flags.
Okay, good. Now this is a good point because when you say you bring this up with the employer, most of us are worried that I've got this great job offer in an area that I want to be in and it's with a really good private practice, let's say. I don't want to piss them off.
Exactly.
How does, do you advise that you bring this up with the employer? Do you advise that, hey, you know what, I'll talk to John. John will talk to the employer. What's your advice on that?
So it all depends on the physician's, comfort level. Some people will tell us, some people will say, look, I have no problem having this kind of discussion, and we don't need to provide them much, I hate to say coaching, but we don't need to provide much direction at all. Others, they want to learn, and then they ask us tons of questions, and we give them, hey, here's how you say it, right? And you can almost hear them taking notes, on here's exactly how I'm going to say it to not upset the employer. And because again, it's not only the what you ask, but it's the how you ask it. And it can also be the when. And if you're negotiating something like compensation, the order in which you ask for certain things like salary or incentive compensation or signing bonus or relocation or stipends or retention bonuses or student loans or et cetera, right. The order that you ask and the way that you ask can be have a dramatic impact on if you receive those things or not. And then depending on their answers, again, how you ask follow-up questions to make sure that you do have their best and final offer and that there are no discrepancies with what they've offered or given other physicians. And so sometimes, again, our goal, we have multiple different packages, but our goal is to, again, we look at ourselves as educators. And if we can educate the physicians on what this thing says and what they need to know, and then if I were in your shoes or if we were doing this for you, these are the things that we would ask. Right. You can just like I can take my doctor's advice on managing my diet and my exercise level, or I can say, I'm going to do it my own way. You guys can take our information and do nothing. You can, do it exactly like we said, or you can do something that you choose to, but having us there to bounce ideas off of, I think can be invaluable, or anybody there for that matter can be valuable. And so it all depends. As you can imagine, there may be different specialties who are more comfortable with that seemingly, that conversation. And there may be others that are a little more timid and less likely to push and ask. I'll be honest, we do see discrepancies with male and female pay. And there's been a lot published on it, a lot of literature, more stuff recently coming out. We see discrepancies in lots of different specialties. Surgical specialties is the biggest area for male and female, compensation differences. And so again, knowing what those trends look like and then sometimes all we do is we just provide the confidence that somebody needs to ask for something, by giving them the way to ask and not come across as I'm greedy and I want more. And so sometimes just the verbiage and the language that we say, look, this is how you ask it's much different than, you can go out and purchase MGMA data. You can call 1,000, people in the specialty and say, how much do you make in this area? Am I being paid, accordingly? But then having somebody to say, here's the how you ask, and then the order that you ask, and then the why you're asking. And that's a whole different ballgame that you just can't get from reading a book, or you can't get from reading a blog, or even listening to a podcast.
Right. No, tremendous. That's a very good point, because you can have all the data you want, but these little key things that you don't really think about are critical to negotiating. So I think that's
and we look at it no differently than how you guys interrogate patients, or speak with the referring specialist on what you feel a patient needs or doesn't need. Right. That you guys have done that thousands and thousands of times, and how to get out of a patient what their symptoms mean, and then analyze it, and then come up with a treatment plan. It's basically all we do. We have a different specialty than you guys.
Right.
We don't treat patients that make them feel better or save lives. We look at ourselves as helping you guys and educating you and showing you what you need to know and how you go about it. And that's why I think, we get along so great with you guys, because we speak your language and we do the same things, and we look at ourselves no different than, I think a lot of physicians. And that's, making sure that you're getting what you need out of the patient as far as asking the right questions in the right order at the right time. And then requesting that the patient follow your treatment algorithm.
Perfect. Well, it's good stuff. I like this. Let's see. So a couple more things about a contract I want to get to, specifically the termination clause. Important, no one wants to think about leaving a job when they're first signing for a job or getting fired from a job, but obviously there's some important verbiage in that they should look for. Tell me what you think is important there.
People look at contracts twice, right? Once when you sign and once when you want to get out or when you're fired. And so, so understanding the termination clause, is very, very important. Most often there's if you can't practice because you're either disabled or you pass away or you don't have a license or you're in jail or, you can't bill a payer, and they can't make any money, the contract ends. Or if a party breaches the contract, usually the other party gets the time to fix it. If they can't, then the contract can be terminated by the non-breaching party. And most common we see no cause terminations, and that's just if you don't want to work here, raise your hand and say, guys, I want to quit. Or if they don't want you, then they can raise their hand and say, Doc, it's been a pleasure, but we're going to ask you to leave. And those vary. They can be 30 days. They can be 10 days. They can be probationary periods. They can be 6 months. And that can be a very important, aspect of the contract. The gold standard is 90 days. We prefer 120 days just because, as you can imagine, we always tell the physicians, ask yourself what has to happen if you get a notice from the employer that they don't want you to be there anymore. Think through what has to happen. I mean, you gotta finish your practice, of course, if they want you to keep working, and you gotta update your CV and find a job, and you gotta interview for it, and you do a site visit, and then you gotta, get a contract and negotiate and sign it, and get credentialed, and maybe a new state license, maybe sell real estate and buy a new home, move, hospital credentialing. I mean, there's a lot that can happen, and it just can't happen in 60 days.
Right.
Or 30 days. Sometimes not 90 days or even. So that's why we like to have the appropriate notice to prevent a gap in income or significant financial losses. But I think it's just important to know, what the employer history is with that. Some physicians want lower numbers. Some physicians want higher. And certain specialties like emergency medicine, they tend to have lower clauses, or independent contractors sometimes have lower. Sometimes academic jobs, or even more rural jobs that are more difficult to fill sometimes have longer notifications periods. So again, I think it's just knowing, what the expectations are, and then, during that period, what you need to be able to do and not do and that kind of thing. But termination clauses obviously can be one of those very important things that if it's not looked at the right way and you don't fully understand how to get out or how they can ask you to leave, that can be obviously very damaging as well.
And I think one of the things that, I've seen in the past, discussing with some of my colleagues is there's been some places, and it may be intentional, unintentional, some asymmetry of that, in favor of the employer. And so it's something to just, they may give you only 90 days, but they may require 180 days notice from you. So just something to look out for. And obviously you guys, you would catch that in your review, but just something to look out for.
Yeah, for sure.
Another thing that I think is kind of a little bit nebulous for most people in terms of their understanding is the restrictive covenant. What are you seeing? And obviously, it's the non-compete clause, but it's variable from state to state. But I'm seeing, or I'm talking to people that are seeing it more and more in there. What are your thoughts on that? And what are you seeing in state?
Yeah, well, I mean, nobody likes non-competes, of course. Again, they vary from place to place. They vary from specialty to specialty, and I think it's most of those, again, when we talk about specifics, most of those are very specific, right? I think the thing to know about non-compete is what's the employer's frame? Do they have an example? Has something happened? Have they enforced one? Have they forgiven? Just so we have some context on if and when things in the future, what that means. Sometimes we'll see we'd like to see it from your primary locations. Oftentimes we'll see it's from any location that you see one patient. And again, if the contract doesn't specify a location, your non-compete could be very, very large. It could be global. Sometimes we'll see any future offices. Well, you don't have any control over how the employer builds offices or does, or buys offices. And so your non-compete that you agree to today could change over time. And maybe you wouldn't have agreed to it, but you're obligating yourself to agree to future changes that you have no control of. Some have buyout provisions or liquidated damages, they call them. It's important to know what those things are and if there's a dollar amount, is it reasonable for the area? And then obviously how it's forgiven, if at all, if it's in place no matter what, or if it's forgiven in some instances. So, some contracts will almost say whoever's fault it is that the employment is ending, that's who will purchase the tail policy. And other times it's 100% on the physician. And again, sometimes it's if you have a claims policy, you'll buy it this way. Well, again, do you have, I guess we're talking about malpractice again, but if we go back to the non-compete, it's just, because we kind of look at the malpractice and the non-compete kind of as the same as far as how it's paid or not paid, how the non-compete is forgiven or not forgiven. But overall the non-compete, we just want to make sure that, it's from a single location. You understand where it's from. the radius is reasonable, and then you understand what frame the employer has for enforcing or not enforcing it in the past.
Right.
And then, and then obviously, do you have any control over it?
Okay, good. Yeah. You're seeing it, but it's just one of those things because you always hear about, well, it's not really that enforceable, or no, it's absolutely enforceable. And I obviously that is more dependent on where you're located as to the legal part of it. But, it's just one of those things that you hear about and no one wants it, but it seems to be there more and more frequently.
Yeah.
So the last thing I want to talk about as far as contracts goes, and this is probably a very small portion of it, but it's something to discuss that has come up once in a while. Side income, such as speaking fees, moonlighting elsewhere, or even if you come up with a medical device, intellectual property, things to look out for there, because depending on if you're at an academic place, especially if you come up with some sort of invention or pharmaceutical, medical device, obviously they'll want a piece of it, or maybe they'll own the whole thing. What are some of the things to look out for?
Intellectual property, some contracts are very specific, and others, they don't have anything. So it's obviously important to know what any policies they may have that are written down somewhere else that you haven't seen, if that kind of thing is important to you around intellectual property. Some employers require most employers require approval and consent to do any outside activities. Others are less caring. So again, if those things are important to an individual physician, it's important to have those things delineated in the contract. One of the things that we're seeing a large evolution, if you will, of telemedicine.
Right.
And, how does telemedicine impact things like non-compete? How does telemedicine impact things like outside activities? So if they say you can do whatever you'd like during your employment as long as it's outside the area, or nights and weekends, well, if you're working from your current location, but you're doing work, quote unquote, in a different area, how do they look at that?
Right.
And so those are some things that we encourage discussions with the employer ahead of time, or if it's that important to the physician, to make sure that they have something specifically put in their contract that kind of pre-approves them to do certain activities that the employer may want to get approval for.
Right.
Most of the time, the employer they have your best interest in mind. They want to make sure you're protected, you have the right insurances in place, that you're completing your obligations for them first. And there's different rules and regulations with some of these reporting mechanisms and everything else. They want to make sure that they keep you off the front page of the paper, because they feel that doesn't look good for you or doesn't look good for them. And so sometimes they just want to, they're more of protecting of your time.
Right.
But a lot of times they can be sometimes overly bearing and controlling, depending on what it is exactly that you want to do.
Right. Okay, good. Well, this has been some really good information, Jon, and I want to thank you. Tell our listeners where they could find out more specifics about your company, the different packages that you guys offer.
Yeah, so we're online. ContractDiagnostics.com is our website. Anybody can always email me specifically. I'm just Jon, Jon, at Contract Diagnostics. Anybody can call our 800 number. It's 888-574-5526. And we have a contact us form on our website. People can always just hit us up, and then we reply with emails and follow-up calls and that kind of thing. Or they can always email info@Contract Diagnostics, and my admin will find a way to get the physician in touch with somebody on our team or get them the information that they're looking for. So we are, we're here to help you guys out. We have multiple different packages. They start as low as $200, and they work their way up from there. It obviously depends on if it's just kind of if it is one of those kind of, check the box kind of things, or if it's more of an intricate, we're going to reach out to the employer and we're going to discuss things with them. And, we're going to do a lot of documentation, have a lot of touch points with the physician. But everything that we do is all flat price. We don't, so the expectations are set up front. We don't do a lot of back and forth. We find that, we don't do a lot of back and forth, like sign here and read this and 4-page document, big contract. We find it kind of ironic.
Right.
Anybody would do that. But everything's online. It takes about 1 minute to start. They can book times. Our usual review time is about 3 days out or 4 days out. Last week was super busy. I think we were maybe 6 days or 7 days at our quote unquote busiest time, or our worst. We were pushing people back longer than we like to. But we're efficient. Everything's easy. It's all online. We work the schedules that you guys work. So we do reviews between 6 in the morning and 10 at night. We do weekend reviews, and we do calls on Sunday nights, times that we realize our client can't always do between 9 and 5.
Right.
So we open our schedules up to yours to make it easier for you guys to find time that's easier, and email back and forth, have other ways of interacting with us other than, a quote unquote call or a meeting during the typical business hours.
Great. Well, thank you. This is, like I said, it's been really, really good information. And obviously no one wants to go into employer-employee relationship as an antagonistic thing, but you want to be protected and they want to be protected. And, there's a lot of terminology that we just, as physicians, had never been taught. So thanks for clearing up a lot of that. And I hope our listeners will reach out to you with any questions.
Yeah, absolutely. And I'll tell you, on our website, we have there's a button. We have a free 15-minute, consultation. Anybody can call. Again, we're here to help and provide value in any way that we can. And if that means doing a formal review, which means charging you, then that's fine. If it's just providing 15 minutes of our ear and hearing a little about your situation and then providing here's what we would do, that's what we're here for. And so, anybody can call anytime and ask any questions that they want to. And we'd love to give them 15 minutes of our time and see what we can do to help them. We don't charge for that. It's just something that we do because we're here to help. So people can always take advantage of that too. If it's just questions on how to go about an interview or questions on what not to say, or here's my situation. I'm in an employed situation and I don't know what to do. We're here to bounce ideas off of and just catch our ears. So we encourage people to reach out, whether it's for a formal review or just to kind of share their situation to see, what we could do to help, if anything. So
perfect.
So they can definitely do that as well. But yeah, we look forward to continuing the conversation. If there's anything else that we can help your folks with, or if you guys have any other questions for us, we'd love to get on and do this again. We have a great time doing this, and it means a lot to us. Because again, we're here to help in any way that we can. So,
all right. Well, thanks, Jon. Thank you once again, and we probably will come back in the future and discuss some changes in contracts and other questions that our listeners may have. So, I want to thank you.
You bet. I appreciate it. I hope everyone has a great week, and we look forward to continuing the conversation.
Thanks for listening to another episode of the Dr. Money Matters podcast. I want to thank my guest, Jon Appino of Contract Diagnostics, for a very thorough and informative discussion on physician employment contracts. I encourage you to take a look at Jon's website, www.contractdiagnostics.com, for more information. Thanks again for listening and subscribing to the podcast. We're starting to gain subscribers and the number of listeners, so I really appreciate that. You can definitely, I encourage you to definitely share this episode and and the podcast in general with your physician and dental colleagues, and hopefully they can gain some value from it too. Please continue to leave us reviews on Apple Podcast, iTunes, Google Play, or wherever you get this podcast. And you can follow me on Twitter at Dr. Money Matters, or on Instagram or Facebook at Dr. Money Matters, all spelled out. You can also visit our website where all the podcasts are archived, www.drmoneymatters.com, all spelled out. And as always, please do your own due diligence before engaging in any changes in your financial situation. If there are any topics that you feel should be discussed on this show, please message me on Twitter or Facebook or by email at comments@drmoneymatters.com. Thanks again, and another episode will be coming soon.